Good afternoon, and thank you everybody for attending our panel discussion for Working Group 4, which focused on women and girls with bleeding and those with the potential to menstruate. My name is Sarah O'Brien. I am a pediatric hematologist at Nationwide Children's Hospital, which is part of the Ohio State University. I wanted to thank Len Valentino and Michael Recht for inviting me to serve on the executive committee for this wonderful State of the Science initiative and to represent the Foundation for Women and Girls with Blood Disorders on that committee. I'd like to thank Maureen Baldwin and Angela Wyan for doing a fantastic job of chairing this working committee and for a wonderful summary of their presentation that we all just watched, and to thank all of the members of the working committee for I know it was a lot of time and effort. Many of the people on the screen you've met before. In this session, I'm going to briefly go around because I don't want to take a lot of time away from discussion. I think you've met the chairs. Maureen Baldwin is a gynecologist obstetrician at Oregon Health and Sciences University. Angela Wyand is a pediatric hematologist at the University of Michigan, and they served as the co-chairs for this committee. We heard a fantastic lecture from Dr. Wendy Court, who is a basic scientist at the University of Colorado. We also heard a perspective from Shelley Horowitz, who is a licensed school counselor and a school administrator, and as you learned, is also a patient with hemophilia. She also does a lot of fantastic writing and blogging to encourage women with bleeding disorders to advocate and be heard. Joining us today, we also have Kristen Nunez, who is a genetics counselor at Duke University. We have Don Rodolini, who is the Chief Operating Officer for the National Hemophilia Foundation. We have Christina Haley, who is a pediatric hematologist at Oregon Health and Sciences University. I think I got everybody. And then we have our always present Len Valentino and Michael Recht from National Hemophilia Foundation and American Thrombosis and Hemostasis Network, who I hope have a vacation planned at the end of this State of the Science. So I wanted to start with a lot of your talk today, Wendy, generated a lot of discussion and questions already. And so I'm going to go through a few of the questions that the audience has already asked. One question was talking about, actually it was submitted by Len Valentino, and I liked his questions. Can we help to mitigate any of the changes due to loss of estrogen? Or as he phrased it, is it a quote, lost cause?
Well, thank you, Sarah, and for that question, Len. I tried to cover some aspects of, I'm actually trained as an exercise scientist, an exercise physiologist. That's what my doctoral degree is in. And I'm very interested in the extent to which we can mitigate some of those metabolic and bioenergetic consequences of the loss of estrogen that I presented by lifestyle intervention, and specifically through exercise. And we have only very preliminary data to address that question, but I'm both heartened and disappointed at what we've seen so far. Some of the changes do not appear to be modifiable by exercise, at least based on preliminary data. And one that I was very surprised by was the increase in abdominal adiposity that occurs in women, because that would be predicted to be a risk factor that is heightened, that risk for obesity-related diseases like type 2 diabetes, cardiovascular disease, hypertension. And at least in the studies we've conducted so far, that is very modifiable by estrogen. So estrogen seems to protect against fat accumulation in the belly region, but it wasn't touched by exercise. And that particular study that we did was resistance exercise, muscle building types of exercise, which may not be the best for enhancing energy expenditure in a way that could minimize the gain of fat during a time when women seem to be at increased propensity for weight gain. The studies we've done with endurance exercise or cardio types of exercise have been a little bit more effective, but still not fully effective at preventing that. One other outcome that I'm very interested in, because half of my lab is focused on bone metabolism, is whether the very potent effects of estrogen on the skeleton can be prevented, the loss of bone prevented with estrogen deficiency. And there again, exercise has some benefit, but not fully protective. So women should not be of the impression that they can prevent osteoporosis in their postmenopausal years just by exercising and taking vitamin D and calcium. That's not sufficient for the majority of women.
Can you talk a little bit about, joint and bone health was identified by the working group as a research gap. And I think your talk made me think about how when we're collecting data from patients in these future studies, it'll be important for us to document what their exercise patterns are so that we can see how that is a variable in joint and bone health. Can you help us understand in practical terms what is endurance exercise and how would we want to collect that behavior in a research study?
Yeah, endurance is the cardio types of exercise. So exercise that gets your heart rate elevated, and if you're doing vigorous endurance exercise, you're breathing hard, you're sweating, and so asking people if they are physically active enough where they would have trouble carrying on a conversation if they were walking or jogging or biking with a friend. That would give you a sense of whether they're doing endurance exercise at an intensity where we would expect some of the physiologic benefits to occur. So if they're quite fit and just going out for a stroll, you're able to carry on a conversation, and that wouldn't really be the moderate to vigorous level of exercise that we would want someone to try to achieve. And endurance exercise contrasts with resistance, where it's muscle building, it's lifting weights, or even using your own body weight to try to build muscle mass. So those are the two general types of exercise that we typically try to focus on and promote.
Great, thank you. So I already warned our co-chairs that I'm going to put them on the spot a little bit. So many research gaps were raised in general areas, but not a specific study that we would do. And I know you talked in your group about impact and resources and feasibility. So I go home from this session, I win the lottery, and I have $1 million, and I'm going to give it to each of you. What study would you start next week that you think could make the biggest impact for women and girls with bleeding? I'll go in alphabetical order and start with Maureen Baldwin.
I thought you were going to take alphabetical with Angela, but I want to first say thank you, Wendy, for what a wonderful talk. That was so great, and it was great, Shelley, to hear also about your story. I think that my bias as a clinician who takes care of teens with heavy menstrual bleeding, and also with my background in family planning and contraceptive education and management, I think that one of the biggest pressing research areas that really impacts our ability to provide the treatment that we actually know is effective is having patients understand that when we talk about hormonal therapy that is currently FDA approved and marketed as contraceptives, that we're not just talking about contraception. And so this intersection between contraception and hormone therapy throughout the lifespan really I think needs more attention and research in the bleeding disorder community, and to understand that when we give an 11-year-old norethindrone progestin medication for her acute heavy menstrual hemorrhage, that we're that we're, giving her a medication, not a birth control. And for her family to understand that that's not stigmatizing, and for her to be able to like carry on and go to school and not have to worry about all the impacts that anemia has on her life. And that's something we face a lot as clinicians. I think what kind of research study would that be? I think would be including these patients in those research studies and having comparative trials of hormonal medication therapy for people with bleeding disorders. That's where I really would start. And I think that, as we talked about in our talk, the foundations for being able to do those phase 3 trials are these high costs of measured menstrual blood loss.
Yeah, I agree with Maureen. I think one thing that really struck me when we were going through all these questions, I think it was Christina actually that brought it up one day of like, we kept talking about all these things and what data we have and what data we're lacking, and how, she pointed out that all of the data that we have is in men, and that we're just trying to make women fit into these boxes that we've, found fit men. But there's no real reason to assume that women are going to fit into those boxes. And so it really feels like a foundational issue. And I agree, like the measurement of the menstrual blood loss, I think is huge, because when you think about new therapies and wanting them to be approved, there's a certain level that the FDA requires. And it's very difficult to actually gather that data to say this intervention is, helpful for heavy menstrual bleeding, because most people are not going to want to collect their pads and their tampons to have them measured and weighed.
To others on the panel, what else do you think from the patient perspective might be barriers to participating in studies of hormonal medications?
Go ahead and answer that, Sarah. I think that Maureen brought up a really important point, that when you look at barriers, the perception about why I'm using hormones and what they're for, I see even from the patient perspective as one of the largest barriers to wanting to participate in a research study. I will also say, though, from my connections with individual women with bleeding disorders, many women want to be a part of research. They see the benefit, they see the value, and they see the gaping hole that we have right now. And my sense is that in many cases, women are ripe to get involved and participate. And in most cases, they would very much appreciate the opportunity to be counted and included in research.
Thank you for that perspective. I'm going to push back a little bit. I've heard that raised as a barrier in this working group, and it came up in discussion in some of the other working groups about how the inability to measure menstrual blood loss is such a barrier to research. And this comes up a lot when I'm speaking with industry partners and trying to get them excited about studying this. So I'm gonna take moderator's prerogative for a minute. And I want to read to the audience the ISTH SSC's definition of how to measure a joint bleed, which is an unusual sensation or aura in the joint in combination with any of the following: increasing swelling or warmth of the skin, increasing pain, or progressive loss of range of motion or difficulty in using the limb as compared to baseline. And when I read that, that sounds pretty subjective to me. And so it made me think, why is this such a barrier? This is how we've been measuring outcomes for years in studies of patients with bleeding disorders. So based on what we know so far, what are your thoughts on what is the best way today to measure menstrual bleeding, or patients' perspectives on their menstrual bleeding, so that we know whether it's getting better on therapy? And Christine, I'm going to pick on you for this, because I know you've done some work on how we can assess patient-reported outcomes when it comes to menstrual bleeding. So I'll pick on you.
I was thinking actually the same thing, Sarah, as we were talking about that. Is this a barrier, or does it have to be the barrier? And could we just choose a different a different definition or a different outcome instead of measured bleeding or measured blood loss? And could it be, I think about your guys's original study from your clinic, and that the one of the best predictors of a bleeding disorder was whether the patient themselves reported their bleeding to be heavy. And can't we just take that? And is it as simple as a Likert scale of my bleeding as heavy, 1 to 5 or whatever it might be? Or is there a better outcome measure of missed days of school, missed days of work, or anemia, or low ferritin? I think that it feels cumbersome and potentially unnecessary to do the measurement. I think it's always nice to have like hard data, but maybe we just need to get over that desire for that piece of information. I don't know. Maureen's gonna weigh in though, I think.
I just wanted to just comment that I completely agree, and I'll agree with you, Sarah and Christina, that we don't need to measure it. We shouldn't need to. I mean, you can stand at a birth and say that was a hemorrhage, and you don't need to stand, count everything. And you can know that, this person is really anemic and is getting better on whatever medication you put them on. But it's the FDA. The FDA actually requires measured menstrual blood loss to be able to do phase 3 trials to approve the medication for that treatment. And so maybe we can just get around that, and patients will all of a sudden accept that, this birth control pill is actually period pill. But I think that it would be great to get it on the label so that we can have it covered by insurance in all states.
We have a few questions from the audience on the theme of, if anyone can speak to this, and I don't know if it'll be probably not exclusive to bleeding disorders at this point, but are there studies in the works, or what have we learned so far about the differences in hormone effects when they are being taken by members of our trans community, for example, and are the effects, how does that affect their health and some of these outcomes? And do we have any idea on how that hormonal therapy would affect menstruation in patients with bleeding disorders?
I'd be happy to start with just a comment on this, because I've got 2 postdoctoral trainees, one who's a pediatric endocrinologist and another who's an adult endocrinologist, who are running our transgender health clinics here at Children's Hospital and University Hospital in Colorado. And I think we are just beginning, in this country anyway, to learn about the impact of blocking puberty in trans kids, and then also learning about what the impact of hormone therapy is once they start their cross-gender hormone treatment. I think it's too early to make any generalizations, that knowing that, these are the effects. It also is very heavily dependent on the type of hormone regimen that's used. Both the type and the route of administration is also important. Oral estrogens promote clotting. We think that transdermal estrogens reduce that risk, but there are also concerns about the different types of progesterones and androgens that are used in these treatments. So I think it's very, very early in the transgender research world to say that we know what the effects are. I know that just this morning I saw a news brief flash across my computer of, I think it was one of the endocrine sources I get, saying that transgender individuals are at twice the risk of dying at a certain age than their cis counterparts. So we have a lot to learn, because we don't know if any of that increased risk is attributable to the hormone treatments that we provide for them.
Thank you so much, Wendy. Anybody else have any comments on that topic?
I think Kristen has her hand up.
Go ahead, Krista. Thanks.
Was it on this topic?
I just put it on in the little chat. This actually goes back to, well, I put it in the chat. Will you let me know if you think it's worthwhile sharing it? Because it goes back to the topic that we were discussing about menstrual loss. We can keep going if you want.
I wanted to add that we do have burgeoning data coming out about preferences for menses from patients who have a range of gender identity, and ranging from seeing themselves as male to very feminine to somewhat feminine to moderately feminine, and that that it's really difficult to analyze because everybody has individual preferences, and so large samples show us so far that that mainly most people who don't identify as extremely feminine prefer to have amenorrhea or almost no bleeding at all, but that irregular bleeding is a big problem. And that's probably very similar if you ask most people. But this identity preference for patterns is something that's just beginning to be studied.
Thank you, Maureen. Kristen, going back to your point in the chat box, which goes to this issue of how do we best measure menses, I think your point is great that we need to develop better products to help with these research studies. Like we have cups now that can measure menses, but could we somehow tie that to a smartphone? Or period panties are taking off in popularity. You know, how can we use those to help measure menses? And it's just a changing world. And I think recognizing that that's very specific to patients too, how they prefer what products they prefer to use during menses, and that can be a barrier to research. Also, I think if you're trying to prescribe a particular menstrual product that they have to use in order to participate in the study. Somebody in the chat has raised the question on, and I'll separate it because they're asking about gaps in funding and gaps in infrastructure. So I think first let's touch on infrastructure. What are the addressable gaps that we see within our own HTC or institution structures that may limit our ability to do research in women and girls?
Can I talk?
Yes.
So I
Sorry,
think
your hands are blending into the background, so sometimes it's hard for me to see them.
I think that in my mind, a lot of the issue, I think people have tried to do studies with women before, both kind of drugs sponsored as well as, investigator initiated. And a lot of times there's problems with recruitment. I think identification of these patients is difficult. And that, I think a lot of HCCs don't have a formalized way of identifying, we know that there should be a lot more women affected by hemophilia than there are currently in registries, just by the numbers. But I think we're missing those patients. I think that's kind of the lowest hanging fruit for identification of patients versus, more like primary care identification to recognize abnormal bleeding. But I think that is one of the biggest hurdles that I see.
Christina, can I ask you to touch briefly on what you learned through your review of the published review of the Athen data set with regard to bleeding in women and girls?
Yeah, I was just going to unmute. So thank you. In our review of what was in Athen, this was a few years ago, was that a quarter of the women in the registry reported or were noted to have heavy menstrual bleeding, which doesn't match with what we're seeing clinically. And I think goes back to, as we were working on with our study through the DREAM Award I was awarded, was to look at how do we record or do a registry a little bit better of keeping track of women specific symptoms or outcomes. And I think that's what I was thinking about from an infrastructure, is that, and it goes back to what Angela was saying a little bit ago, of that we continue to start from, this is what we have for men, and then let's figure out what it means for women, rather than let's think about what's going on with women. And so I think that was our challenge for getting some of the data out of Athen, that hopefully we'll get some additional data through our study, is to say, oh, these are the data points that are most helpful to understand how to track women long term. But it goes back to what's the, how do we create that opportunity to step back and think about women independent of men, or as like just like separate symptoms, that it's so that we can understand and figure out what are the outcome measures that we do need to track. What is the long-term information that we need, or like how does the uterus affect hemostasis, and like all those things that we don't understand. And just like, I think from an infrastructure, it's a push to force all of us to step back when we're asking the question to reframe. Are we looking at this through the lens of males with hemophilia? Or are we looking at this from the question of like, what is this bleeding disorder and how is it affecting this woman?
I think one thing that comes to my mind is that I've been working at the same HTC for 15 years now. And I think the interest and the number of patients we have with regard to women and girls with bleeding has exploded since I've been here. But we have the same number of nurse clinicians that we did when I started 15 years ago. And I don't know if that's what others have seen, that the interest in this is growing, but our HTC staffs haven't grown to meet the needs of this new population. Have others experienced this crunch at their own sites?
Yeah, I think we have as well. We're currently, through the Foundation for Women and Girls with Bleeding Disorders, collecting that data from a lot of different the LAN members. We're looking at the number of females that are treated, both with the creation of new focused clinics, but also at places where they don't have specific focused clinics. And so far, all of the data that we have is that those numbers are increasing significantly, and it doesn't feel like the support is necessarily increasing in an equivalent manner. So I think a lot of times it feels like the people who are really invested kind of do it on top of what they're like. We've had, nurses that are really interested in this, that take additional time that they wouldn't otherwise be working to devote to this sort of thing. But we can't always just count on those sorts of people.
For audience members and patients and families that may be listening who are not familiar with the LAN network, can you briefly say what that is?
Sure. So the Foundation for Women and Girls with Bleeding Disorders has what they call the Learning Action Network. So there are kind of different sites that are involved, and we have had an annual meeting for I don't know how many years now, it's ongoing, where we kind of talk about best practices for these types of clinics, research that can come out of these sorts of clinics, and just how to kind of improve the care of these patients.
Kristen, did you have your hand up? Or is that an old hand? Maureen, I'll ask you this next question first. Asking about what the impact of ovarian cysts and endometriosis is in women and girls with bleeding disorders. And I think it's also important from a research setting as we decide, like, can you be included in these studies if you also have endometriosis, or how should we be thinking about those issues when we're assessing and trying to study heavy menstrual bleeding?
I think from a research standpoint, it needs to be pretty clean and not include these patients. However, this is a subpopulation that's really important, because from a surgical standpoint, just as a gynecologist, I can tell you that we need specific data on how do we do surgery on a patient with frequent ovarian cysts, that also bleed because of their bleeding disorder. And that's a common surgery at some institutions where they focus management for younger girls. So I would say from both perspectives, if we're looking at management of general bleeding disorder in this population, people with ovaries, then complications with ovaries should probably not be included. But if we're talking about how do we manage endometriosis and bleeding disorder, that's a subpopulation that actually really needs a lot of attention.
Shelley, do you find that you hear from the patient community that diagnoses of endometriosis and ovarian cysts can be barriers for women to getting a diagnosis of an underlying bleeding disorder?
Yes, I think any diagnosis that can shift the focus away from a bleeding disorder, unfortunately, means that sometimes it can be missed. So I think anytime you're dealing with a comorbidity, you run the risk of delayed diagnosis of the bleeding. And I've certainly heard that from many women who have both a bleeding disorder and a comorbid other issue that they're dealing with simultaneously.
One question from the audience is, what are the highest priority basic or mechanistic biology research questions? So can you talk a little bit about what may have come up in your working group discussions on what we need regarding basic biology? I'll pick on Angela first.
I was actually just unmuting, so you don't even have.
Oh, perfect.
I think one thing that came up within our group repeatedly is the idea of kind of local hemostasis, like how uterine hemostasis may differ from more systemic hemostasis. I think that there were a lot of talks about, historically it has been felt that more primary hemostatic defects like von Willebrand's disease or platelet disorders have a lot more heavy menstrual bleeding than factor deficiencies may. And whether that's true or an artifact of how we were collecting data, I think it is not really known. But how is there a difference in uterine hemostasis between more primary hemostatic mechanisms or secondary hemostatic mechanisms? I think a lot of that is still unknown, and I think we've all seen those patients where they have horrible periods, but that's it. Or vice versa, maybe they have horrible other bleeding, but somehow their periods are okay. So clearly it seems like there may be some difference there.
And I'll just add that, as was talked about in the von Willebrand session about connective tissue disorder, the vascular impact of connective tissue disorder at the level of the endometrium and where vessel bleeding occurs for the uterus is something that we really know very little about, and very little also about how to treat it.
Thank you so much. Can you talk a little bit about, and I think this goes back to the point of we need to get women into the clinic to even be able to study them properly. So one audience member asks, how do you think our HTC model needs to adapt to be more inclusive of women and girls?
I think, and I noticed Robert Sidonio had asked a question about whether, it should be separate, like a separate dedicated clinic, or whether it should be kind of within the larger HTC framework. And I think I can see pluses and minuses to both of those things. I think in my mind, one opportunity that I think that we are not always taking advantage of is the fact that we have these long comprehensive clinics with our male patients in pediatrics, and oftentimes their mother is there or their sister is there, and kind of utilizing that time to, have them do a self-bat or talk to them about, getting factor levels. I think would be an easy way to capture that population that otherwise may be missed. But I'm not sure what the best answer is. I'd love to hear what Robert thinks as well.
I wanted to say that, this is a hot topic among patients for sure. And there's always a balance because women need to have their needs met, and they need to be validated, and they need to have their bleeding issues addressed appropriately. And yet inclusion of women means that if we're always in a separate space, we're not being included as part of that greater community. So I think that there's a real balance to having those separate clinics, and then making sure that in the discussions of men with bleeding disorders, that women aren't an afterthought, but remain an important, critical part of those conversations as well.
Kristen, can I ask how you approach this, or has your practice changed over the years? As I'm just imagining you taking a pedigree with a new baby with hemophilia. And do you find that just in taking that pedigree, sometimes you're unearthing bleeding in women that they've never really thought about before?
Absolutely. I've been doing this for about 15 years now, and I think it's actually putting, again, these undiagnosed women into spaces where proper diagnoses can occur. And then also thinking about other genetic conditions or the genetic conditions that they were diagnosed with that have underlying bleeding concerns as comorbidities that need to be addressed. I think the biggest thing for me, for patients, particularly in the prenatal world where I lived the majority of my time, is this idea of being supported during their pregnancy or even pre-pregnancy. Who do they reach out to try to get the information that they need to not only get a proper diagnosis or to determine if they're a carrier, but whether or not their variant might be associated with more significant bleeding during a reproductive procedure like oocyte retrieval, or are they at a greater risk for bleeding during procedures like CVS or amniocentesis, and how do we manage these women through labor and delivery while also managing and taking care of their children who may be at risk. I think certainly within the genetics community, there was a long time belief that you don't test minors. Well, we know that testing minors and identifying their variants as early as possible are helpful in their medical management. But yet women, young girls, still remain sort of the outlier for being able to be offered that. And that's further supported by a lack of support from payers to sort of not recognize them as having a diagnosis as well. I'm probably getting onto more of a soapbox than you asked, Sarah. I apologize. But I do think that the landscape is changing. And I actually would like to applaud the women with disease who suspect that they have disease but may not be diagnosed, and all the clinicians who work with these patients, that I think it's really I used the word groundswell before privately, but it's that groundswell, that desire to want to be seen and heard and to be activists in their own care. It's really changed how I practice.
And this ties in nicely to a question from Alana on the NHF staff asking, what are some recommendations we can give women to help them start these conversations with their physicians regarding their concerns about bleeding, reproductive health?
I had a session at NHF where we talked about this a little bit and had 3 different patient panelists that were kind of talking about this. And I think what really struck me was how many times a lot of these women are dismissed by physicians, whether it's, some of their stories were hematologists at HTCs, and a lot of their stories were in the ER where someone laughed at them and said, you don't understand hemophilia, women don't have hemophilia, or primary care or other places where, they were dismissed. And I think from those patients, I feel like, just being as educated yourself about these sorts of things so that you can advocate for yourself. And so that when you are dismissed, you're able to push back with some evidence or some data. And, some of the stories they told were horrific. And there were times where it was like, you can't salvage that therapeutic relationship after a physician says that to you. And so hopefully you're in a situation where you can seek care elsewhere. But I think, the more knowledge you can equip yourself with to be able to push back on some of that stuff and to not, take one physician's dismissal to mean that you don't have a real problem, if you're having symptoms that are interfering with your life, to continue to seek out other people.
Sarah, I just wanted to add to, I think, in addition to what Angela said, if it's taking like a self bat and bringing that information of this was my score, or, that to your physician. But I also would say we should turn it around to how do we do some research on the education, medical education, and push for improving, is it as simple as making sure when there's questions about hemophilia on boards that some of the stems have women in them, or can we do some better work to educate the medical team so that women don't have to advocate so hard to be heard? And I think there's some research that we could do in that, in addition to just like simply doing some education.
I really like what Dr. Haley had to say. I think that it's really important that when possible, we work from the physicians down. Not every woman has access to information on X inactivation to go head to head with a physician who might not understand that a woman can have a bleeding disorder. And I think that anything we can do to educate the medical community on so many levels, primary healthcare providers, dentists, nurses, who might come in contact with women who are bleeding, would be a big relief to patients who may not have the capacity to or the courage even to find that voice to self-advocate.
If I might add as well, I think there's an enormous opportunity right now with the advancements of hemophilia care and treatment, in that there are going to be more mild and moderate phenotype out there because of the different treatments. This is a perfect opportunity for us to advocate for women to be included in that mild and moderate discussion. So I think that this is aligning nicely right now, but we just have to raise our voices.
Going back to what Kristen had been saying about identifying that there might be a mom or sister who could get screened at the time of perinatal screening, and also to what Angela was saying about trying to identify who are those people in the HTC who could also benefit in the family for getting screened. I think that we can think also about the time around birth a little bit more. And we talked a lot in our group about this identification of hemorrhage at the time of birth as a big milestone time period where we can really help people identify if there might be need for the neonate to be tested, and also for the person giving birth to be screened or tested later. And I think that that it is the education of the medical staff to the patient at the time of the birth that's really lacking. And we are also not counting this, since there's other reasons for hemorrhage at birth. We don't want to traumatize the patient with a hemorrhage. We sometimes just kind of cover it up a little bit, and it gets put on their discharge summary as, mild hemorrhage. So identifying how we can better educate patients about what happened and what they may need workup for later surrounding birth was a huge highlight for research that we came up with in our group too.
Absolutely. I don't know if you discussed this at all in your working group. I think one of the challenges with research regarding childbirth is, even in our women with established diagnoses, oftentimes they're delivering their children at another hospital, whether we're a pediatric hospital and they're delivering at the adult hospital, or we've been able to connect with local providers so that they can have their delivery there. How do we still make sure that we're capturing that information in our registries, or that we're able to do research even when women aren't having their children next door to us?
I think I think that the American College of Obstetricians and Gynecologists is really working on trying to roll out this quantified blood loss at the time of birth, and that most academic centers are doing quantitation. We weigh all the blood products and the pads and the fluid and try to make these estimates using a spreadsheet on every single birth. It's a lot for a community partner to try to accomplish, but paring that down for community partners to be able to at least give a number to the blood loss at the birth is somewhere to start. And I think that's their first charge.
Mike, can you speak to at all how Athen approaches this? Is this a problem in the Athen data that women's births aren't recorded, or if they are, no details are provided?
So thanks for that question, Sarah. That is a problem with the data that is collected in the Athen systems. The just going back to what Christina talked about in her Dream Award, the Athen data set was created for men with hemophilia, boys and men with hemophilia, essentially. And through Christina's project, we have certainly formalized and expanded the type and the amount of data that we're collecting on women. I think the biggest issue is the issue that we just talked about, is that actually very few of the babies that are born, or the women who are delivering, deliver at the hospitals where the HTCs are. So that good, solid data is really not available to treatment center staff to get into the Athen data set. Now, Athen has taken some steps to try to address that, in that we are teaming with non-federally supported centers and hospital systems that are now putting data into Athen systems, but still that really doesn't address the issue of where a woman delivers and how we can get that information into Athen systems.
If I could just comment on this also, I'm probably in what would be considered an ideal research environment for this. We have our children's hospital, our university hospital on the same campus. Both use Epic for their electronic medical record, but they have different instances of Epic that aren't harmonized. So those data are not easily integrated. And we have a research database that's been developed through the university, where clinical data from both Children's Hospital and University Hospital come together and are harmonized, because we have a very strong maternal fetal health program here that require the integration of those data. So even at an academic medical institution where this should be happening seamlessly, it doesn't.
If I can reflect on that a little bit. So the first thing I want to reflect on is, Dr. Court, thank you for that amazing talk. That was just perfect and really a great lead into our working group session. The second is Athen is working with Akron Children's Hospital for us to be able to, and talking to the computer people at Athen, I think the official term is suck the data right out of Epic into Athen systems. So there isn't that human that would be required to look at an Epic chart and put it into Athen systems. Because of COVID, that project went to sleep for a little bit, but now it's back on track. And we have about another dozen hospitals that are lined up in order to have this sort of Epic integration right into Athen systems once we can show that it actually works with Akron. So reflecting, Dr. Court, on what you said in Aurora / Denver, what people don't understand is children's Epic and the adult hospital's Epic could be two completely different things, even though they're both called Epic. So it's actually a lot of work to take that individualized system and pull the data from the right fields and get it into the appropriate fields in the Athen systems.
Thank you. I want to make sure I'm not missing any hands. Okay. I'm going to try to tie together a few questions we've received. One is whether there's an appetite in industry to work with industry to help educate medical professionals on women and girls with bleeding. Another question on what are NHF's current efforts to help educate providers? And then a third question is talking about how can our collaborating organizations work together to help address some of these issues and accelerate research. So I guess, can I ask you all to think about, like, you know, how could we work together with industry and NHF and the Foundation for Women and Girls with Blood Disorders to better educate providers? Angela, your hand's up.
Yeah, so I think there's definitely appetite to partner for education. I think one thing that we can't forget with education is we need to educate healthcare professionals, but also patients. You know, the studies on women and girls who don't even seek care for their abnormal bleeding, the numbers, you know, are impressive. And, you know, ideally we would be able to educate every healthcare provider, but if patients aren't getting to the healthcare provider, that's not going to do a lot of good. So I think there needs to be education on both the patient arena as well as healthcare professionals. I personally think that a campaign through like pads or tampons would be really like a nice way, because the patients who are having the most, you know, abnormal, at least menstrual bleeding, are buying a lot of pads and tampons. And if there was like a little, you know, warning of like, if you're consuming more than, you know, using more than X number of products, you know, per cycle, you should see a doctor. I don't think they have a lot of incentive to do so, as they want to sell pads or tampons. But I think that would be the easiest place to actually reach the patients that are having abnormal menstrual bleeding. I will let someone else answer the question on what NHF is currently doing.
Mike, your hand is up.
Yeah, thanks, Sarah. So I'm lucky enough not only to work for Athen, but I'm on the board of the FWGBD and also Partners in Bleeding Disorders, and which, for those of you who are listening, is a educational platform for people working within the federally supported hemophilia treatment center network, as well as modified availability of educational modules for people who aren't working within the treatment center network. And to go back to yesterday's talk where Dr. Marks talked about how we can modify what we're doing for gene therapy for proteins and plasma-derived factors, we can do that exact same thing through interaction of Athen, NHF, Partners, and FWGBD, in that we've already created this incredible gene therapy content for educating providers and hospital administrators and researchers. And we could take that exact model to create educational modules for people within and outside of the treatment center network. And we have had some interest in creating such modules already.
Len?
Yeah, so I think it's a great question, and I can just say something about sort of the NHF approach, which is, as you probably know, we have several working groups, and those working groups are for physicians, as well as social workers, nurses, physical therapists, and our regional administrators. And I think it's through those working groups that we really want to hear, as well as through all other channels as well. So through the subject matter experts, the people like Shelley who live with these experiences and have a bleeding disorder. We want to hear from, you know, all of the experts, including people who live with these disorders, about what are the educational gaps? How can we best address those? Who are the partners that we can work with most effectively to deliver this education? You know, when I first started here, I made this statement: we have to work together. And, you know, we're stronger if we work together. And I think having a unified agenda and all of us speaking with one voice will really make a big difference to move the entire field forward, and in particular, the field that addresses women and girls and people who have the potential to menstruate, the gaps in care forward. And it's really through this sort of shared agenda that we're trying to create in this research summit that will really advance the care for all people who have inherited bleeding disorders. So, I invite everybody to participate. I think that's really the goal. That's why we wanted to bring everybody together here. And we understand that not everything that we're talking about are strictly research gaps. There's a lot of education, there's a lot of advocacy and public policy that needs to be addressed. And we're hoping that we can collect that kind of information for all of those collateral activities that we'll be able to help support in various ways through community involvement. So, this is going to be a big project for the community to work towards.
Thank you. Dawn, did you want to add something?
I do. I wanted to kind of reflect back to what our working group was talking about, and how important it is to include providers outside of our traditional 4 care team, and including OBGYNs and also midwives was a really big part of our discussion. And I was energized by it, and thinking about what Mike said in the way we approach gene therapy education to go beyond the traditional 4, I think would be a phenomenal way to approach that for healthcare providers. So I just wanted to add that.
Can I also add really quickly genetic counselors to that list? I will say there is a group of genetic counselors within the National Society of Genetic Counseling who have bound together to not only be support for one another, but for support for all other genetic counselors. We have our own group in the National Society of Genetic Counselors, and we are always open to helping you with your message as well too. And genetic counselors, we did a study at Athen. Through Athen, we realized most genetic counselors aren't up to date on their information, but yet are more likely to see these patients because they come from an OB with a family history, and that person may or may not be the individual in question at risk, but maybe somebody else. So I know that the genetic counselors are very interested in being updated, and can also be the ones to help share that message with others.
Great, thank you. I want to circle back to, Dawn, I was fascinated by something you said about how with the current landscape of hemophilia care, soon we will have populations of men and women with phenotypically mild hemophilia. So I'm imagining we're doing a joint health study in that population. Wendy, what do we need to think about based on your talk about, because it's clear to me after listening to you, it's not just how old we are as women that affects our bone health and joint health, but so much else. So how do we categorize women as they're aging, and what do we need to know besides just their age when we're stratifying them into clinical studies?
Well, thank you, Sarah, for that very challenging question. That's difficult. Even in the studies I conduct, I often exclude women 45 to 55 years of age because they're probably in what we refer to as the perimenopause era of their life, this time when hormone levels are fluctuating all over the place. When we screen people to participate in research, we usually, get their blood chemistries at a point in time. It's just a snapshot of this video that is chaotic. So, in earlier years, before age 45 or so, finding out what their menstrual cycle history is should give you a pretty good idea of what their reproductive status is. Now, the caveat with that is whether they've been on hormonal contraception. And that adds a complexity right there because, as Dr. Baldwin knows very well, the estrogen that's used in, I think, almost all hormonal contraceptive formulations is ethinyl estradiol. It's not 17-beta estradiol, which is the most common form of estrogen produced by the ovaries. And there are probably differences in how ethinyl estradiol and 17-beta estradiol are handled, or what effects they have on tissues. So that's one complexity in young women. Trying to categorize women in terms of what their hormonal status is during those perimenopausal years is tough. We've gone to using FSH in the early follicular stage of the cycle as being an indicator of their likelihood that they have reached their perimenopausal years. So we look for FSH to be under 25 milliunits per liter in the early follicular stage. And then in postmenopausal years, that's probably when it's much easier to categorize women, because for most of them, progestins go to zero, estrogens are very low. Androgens can remain variable. So the ovaries continue to produce some testosterone. The adrenals continue to, well, I shouldn't say continue to, the adrenals probably continue to produce dehydroepiandrosterone, or DHEA, which is the dominant precursor for conversion to other androgens and estrogens that determine what the systemic hormone environment is then. So, you know, you may have to do a pretty complex steroid panel to get a good picture of an individual's hormonal status. So it's not an easy question that you ask.
Probably one we need to try to figure out, though, because we know from our patients that this 45 to 55 year window is some of the time when they struggle the most with reproductive bleeding. So we need to make sure that we figure out how to best study that population. I want to raise a few unrelated but important points that I see in the chat for a moment. One of our industry representatives in the audience is making the point that, just true, like we're used to working with industry in the sense of products for patients with hemophilia or von Willebrand disease, but when we're talking about women and girls, that also opens up a whole category of industry that are providing hormonal therapies that potentially we could partner with for our patient population. And there's also going way back to when we were talking about how to measure menses, Kristen Madison is making the point that the National Institute of Clinical Excellence from the NHS in the UK has specifically stated in their guidance for heavy menses that objectively quantified menstrual blood loss is not important. And from the menstruator's point of view, methods to objectively assess reduction in mean blood loss are considered to be poor indicators of treatment effectiveness for heavy menstrual bleeding. So it sounds like we can't get around it with the FDA, but at least when we're doing other types of studies, we can keep that in mind. Donna DiMichele is also challenging us to think about how can sex and gender biology be more integrated into the investigation of all bleeding disorders. So I'll ask people to ponder on that for a moment.
I think going back to what Wendy's comments were, it is just super complicated. It's not just the type of estrogen or progestin that someone might be taking exogenously, but also the delivery method too. We have transdermal, we have transvaginal, transmucosal, injectable. Anyway, I think that we should just start by picking off some subpopulations. If we need to keep our research really clean and defined, we're not just going to open it up to anybody of any levels and age and gender. We want to be real clean and potentially smaller with measurable outcomes. And that goes back to what are our research questions? What are we trying to answer? We do need a lot of descriptive data here on what is the description of this population over the aging life course. But we also have some specific questions like, is this method better than this method in this subpopulation? And we can use some objective outcomes that don't necessarily require measuring things as much as just looking at patient reported outcomes. So there are a lot of low-hanging fruit with patient reported outcomes, for example, with, is the hormonal implant that is marketed and indicated for contraception effective for von Willebrand patients in reducing total, improving their satisfaction? We don't even have the answer to that question. So I think just including the bleeding disorder population and then including lots of other different subtypes is the first place to start.
Thank you. Mike, did you want to add something?
Yeah, I think the first step is understanding the difference between sex and gender. And that is a topic that we at Athen explored about a year and a half ago when we changed actually how we're collecting this data. We had a session at last year's Athen Data Summit that was led by a researcher at Portland State University who helped us better understand how to collect this data appropriately. And we actually changed the way the data is collected in Athen systems to collect the data of sex at birth and then self-identified gender.
And I think, as someone mentioned earlier, it's great that when I've been sitting on study sections in the NIH, it's mandatory that we discuss whether sex is considered as a biological variable, but it needs to go way beyond that, and not just are we counting how many men and women are in the study, but are we also investigating and putting dollars and efforts towards women's health issues. So I think that Maureen gave us her dream study, but Angela, we still haven't heard from you about what you're going to do with the $1 million I hope to win on my way home tonight.
Oh, I mentioned, I think that I was wanting to look at more like the measurement of heavy menstrual bleeding, but now I'm feeling like maybe that's more of an advocacy thing that we need to tackle with the FDA. If we're all in agreement that we don't actually need objective measures, we just need people at the FDA to agree with us. But maybe NHF, I know you guys are really great at advocacy, and Athen too, right?
So I'm just curious, so Dawn's idea about the study of mild hemophilia and joint health, can you all actually see industry doing this study? What would that look like? I will say it's hard for me to imagine.
Sarah, I would ask the question, why do we need industry to do the study?
Mm-hmm. Good point.
So Sarah, if I could just add something, what I can say is there is incredible interest on the part of industry looking at joint health and all people with hemophilia. You might guess what that's based on, right? That there is some claims that emicizumab as a factor VIII mimetic might not have all the effects that factor VIII has. And there is some really good animal data and some emerging human data that people with bleeding disorders in general might have less than optimal bone health. So we actually are in the middle of designing such a study to be put into Athen Transcends to go across all the different cohorts within Transcends. So it would be really the first trans cohort module within Athen Transcends. As we've been designing the study, we've had input from bone biologists, physical therapists, pediatric and adult treaters. What I haven't gotten input in, and this is really making me think, is specialists in women's health, and certainly someone like Dr. Court would be super helpful in making sure that we are measuring the right biomarkers throughout the longitudinal part of the study.
That's what I was just going to say. I'm sure you got, that sounds fantastic. And I'm sure you got some ideas from Dr. Court's lecture on things that you need to include in considering the study.
Very much so. It was a great session.
But I think that your point is really valid, Len, that it's historically so much of the research in hemophilia in particular has been industry driven, but it's really time to think beyond that and what are the kinds of studies we can submit to the NIH and other funding agencies to study these questions in our patients.
Yeah, exactly.
I guess I just want to piggyback on that. I agree. And I want to take it back to the FDA advocacy thing, because that has just been sticking with me this entire time. It's time for us to have that conversation. If that's the barrier for making sure that women and girls and people with the potential to menstruate are included in studies, are included in the data, then let's have that conversation. So Len, go ahead and pick up the phone and let's have that phone call. But really and truly, if we can identify some of those barriers, that's a really clear one. So then let's do that, right? That is something. So if I were to have $1 million, which Sarah, you didn't ask me about that, but if I had the $1 million, this is exactly where I would put it right now.
Well, I think especially with what you had said, Sarah, about like the very nebulous definition of joint bleed, and clearly we have studies where that is the primary outcome. So I think I'm sure there's precedent for it in other types of disease states as well.
Well, and not just having the question of changing it, but having an answer for them too, because get them to yes a whole lot faster by coming up with some ideas that seem like something that is measurable by anybody who wants to do any research related to this would be important.
Because I think those of us who do patient care could probably all say our patients don't come back to us and tell us, we ask about how many pads and tampons they're using, but that's not what they volunteer. They volunteer that they didn't miss swim practice since the last time they saw us, or that they went to prom and enjoyed it. I mean, those are the kinds of outcomes that are meaningful to them. One of our audience members is asking, how do we make meaningful progress on issues relating to aging? What are the questions that I know that came up as a research gap? Can you talk about some of the specific questions you discussed that were gaps in your working group when it comes to aging and women and girls with bleeding disorders?
I think along those lines, we did really focus in on mobility and bone density, as well as joint health. We were also really thinking about the patient-reported outcomes for that population, because we really, none of us live in that realm enough to be able to report on them, and know that that a lot of those people are people who had late diagnoses, and so their lives may have really been very disparate depending on the timing of their diagnosis. So our discussions were mainly just this blank curiosity. And our bone and joint subgroup really was like, we have these very narrowed questions because we really know very little, and we just need to start with essentially an epidemiologic descriptive study of what is the prevalence. And so I was really struck by that.
Other thoughts on aging in women?
I think even outside of the bone and joint, I think our panel was a little bit skewed to pediatric treaters, and so a lot of us talk about heavy menstrual bleeding and first periods and all that different stuff. But I think what we hear from not our own patients, but patient representatives and stuff that we've interacted with is that perimenopausal time can be really challenging, and that I feel like that is a even more neglected population that we need to probably start with, like Maureen said, even with the bone and joint, just with epidemiological data of, what does perimenopause look like for these patients? And I don't know, maybe that's already been done. I don't know enough about that specific area, But
I don't think much. I thought the plenary speaker for the von Willebrand session was fantastic as well. And I had had the opportunity to watch Wendy's talk recording before I saw his talk. And so it just struck me when he was showing those graphs that I've seen so many times before of von Willebrand levels increasing with age. I was thinking about your talk, Wendy, and I was like, well, how much of that is due to age, or how much is any of that due to menopause? And if our von Willebrand levels go up when we're pregnant, do they go down when we're like, I think we don't know so much about how does menopause relate to von Willebrand or factor 8 or factor 9 levels or platelet function. There's very little we know about how menopause affects those levels.
I think it's challenging in our patient population too, that, I think there's obviously cyclical differences with, menstrual cycles, but so many of our patients are completely, we try to completely suppress them. So we're not even necessarily able to, like, it struck me when you were talking about looking at FSH levels at certain points, but so many of our patients have to be, have their menses completely suppressed. So then how do you, I don't know that they have the follicular phase or those sorts of things when they're on some of the treatments that we prescribe.
Wendy, I know one of the questions Angela had about your talk was, speaking of FSH, are there studies in the animals to show, do we know what effect blocking FSH has on bone health?
Yeah, we do. There is a group of investigators who published a paper about 5 years ago on the first study I'm aware of using an FSH antibody. So it's an antibody to the beta subunit, which should block its ability to interact with its receptor. And at least in mice, that antibody was effective at preventing ovarectomy-related bone loss. And interestingly, just a couple of years ago, they followed up and demonstrated that FSH antibody also prevented ovarectomy-related fat gain, specifically in the abdominal region. So I think we are probably doing some of the first interventional studies in humans and animals to try to understand the non-reproductive actions of FSH. So we're studying this in postmenopausal women. We've got this trial going on right now where we're treating them with the GnRH, gonadotropin releasing hormone antagonist that we use in a lot of our studies. We've used this in the past in premenopausal women to suppress ovarian function. But since postmenopausal women already have suppressed ovarian function, what this drug does in postmenopausal women is suppress their gonadotropes. So their very high FSH levels come down to premenopausal levels. And we're trying to keep them on this treatment for 6 months and looking at whether in early postmenopausal women, bringing their FSH levels back down to more youthful levels enhances bone density. And we're also looking at a couple of other outcomes that have been found to be modified by FSH in animals. So we're just on the, the edge of the wave of understanding what actions of FSH might be.
Len is making the point in the chat, Wendy, and I agree that I think you're going to be very busy in the near future, because we've definitely are plan to recruit you to the bleeding disorder community, and you're about to be on a co-investigator on a bunch of different studies.
Well, I will tell you, I know what HTC is. It's not one of my acronyms, but I was actually contacted by somebody from our Hemophilia and Thrombosis Center, who's a trainee of Dr. Marilyn Manco Johnson's, who is very interested in joint and muscle bleeding and being able to quantify physical activity. So I'm already engaged a little bit just as a consultant.
Shelley, not to put you on the spot, but so many research gaps were identified by your working group. What do you feel are the ones that would speak to the patient community the most?
So I actually was a part of a different working group. So I was a participant in a working group, but I was in the von Willebrand working group. So I want to pass that to a member of this working group to answer.
I was just gonna say, I guess that's me. Boy, there's so much. I've got volumes, literally volumes of full notes. But what I will tell you is that we just want to be included and we want to be asked to participate. And I think that, I really loved the discussion earlier about, is it separate clinics? Is it inclusive, being inclusive and heard in current clinics? Yeah, it's both actually. And it's also being asked to be included in data in general. And, we hear about patient-reported outcomes. It would be fantastic to be asked about what our reported outcomes are. So I think that there are so many, and actually this session and listening to Wendy actually reprioritize some of those studies that I think would be, I think we have to answer certain questions first before we can get to the ones that affect our bleeding disorder. But the other thing is reducing the amount of time between first symptoms and diagnosis. And does it, the years and years of bleeding symptoms that happen before you get your first period are completely ignored. And it's only when you have just the massive, super long, non-ending first period that is devastating and mortifying for every preteen or early teen, that's when maybe you'll get a referral from your school nurse, because that's usually where it happens. And then you go down this path of misdiagnosis, going to an OBGYN, et cetera. So just the reduction of that time from the first time you might have bleeding symptoms from a tooth extraction or other things, nosebleeds that are always there on the playground, et cetera. If we could be recognized, and these are women that have long histories in their family of bleeding, not just, spontaneous mutations. So we have a long way to go, but I think just being heard would be the first thing. So I'm not sure if I know I was a little rambly, but it's a lot.
I wanted to add something to what Dawn has to say. Often when we talk about women, we go immediately to menstruation because that's something unique to women. When the definition, Sarah, when you mentioned the definition of a joint bleed, another issue that women have is that when they present with those identical joint symptoms, they are not taken seriously because women can't have bleeding disorders. So in many cases, women will present with those joint issues and not be heard. So I think being taken seriously on multiple levels, not just when we bleed through menstruation. Many patients will say, I'm more than my uterus. And when looking at my bleeding disorder, I'm also more than my uterus. So I think really looking at including all of those areas is critical.
Very important point. Thank you. Len, did you want to add something?
Yeah, I was going to add that, we've gotten to the sort of the toddler stage in this discussion, which is articulating the vast number of problems. And in thinking about, summarizing the information that we learned from the first session with hemophilia and contrasting that with the second session in ultra rare bleeding disorders, it was clear that the amount of knowledge and information in the rare and ultra rare bleeding disorders was vastly inferior to what we know in hemophilia. And I think about today sort of in the same way. We have a lot of information about von Willebrand disease, probably not nearly as much as we do for hemophilia. And when we talk about the issues of bleeding in girls and women and people who have the potential to menstruate, we're even at a more rudimentary stage than we are in the rare and ultra rare bleeding disorders. We're so far removed from really having a clear understanding. So we're now, the next step of this whole process is going to be an implementation phase, where we need to start thinking about how we're going to implement some of the research priorities that you've articulated. And I think that's what's really going to be key, is to get the same voices, but more voices involved, and having the subject matter experts, those people who live with these experiences like Dawn and like Shelley and others who have bleeding disorders, to really opine on what's important to them so that we can make some priority decisions and then help influence other stakeholders like the FDA, like our industry partners, like the NIH, on what are the important questions that should be addressed. So it's really now a time for everybody to pull together and really start, thinking about how we're going to put these into action. We have to stop talking and really start putting some work behind this. But this has been an amazing session. Thank you.